How is the research going on now?
Good. Yeah, the clinical research is picking up. We still have the basic science. We published a paper last year, and
nice.
we're working on a second paper on that, the actin in medulloblastoma.
Oh wow, nice.
Kind of looking at actin signaling in medulloblastoma for migration and proliferation, survival control.
Recording in progress.
But the real exciting thing is now I have a grad student who's working on sonodynamic therapy with 5-ALA.
Oh, nice.
The GBM, and we actually have linked up with our functional neurosurgery colleagues. So we're actually going to be doing the in vitro experiments, but on the 228 on the actual clinical system.
Got it.
So we're using kind of the same mechanical index, like similar processes we would for treatment of a patient.
Got it.
And we're going to be testing the effects on different glioblastoma types, so like methylated, unmethylated, p53 mutants, non-mutated, and seeing if
That'll be
there's
awesome.
variation in the effect of the.
All right, well, we'll have to talk about that when you guys.
I saw you invited.
It's 5 p.m. We're just start live.
Let's start.
Let's start. Okay.
Yeah.
We're going live in 5, 4, 3, 2. Webinar is live.
Wait, we should wait a minute for everybody to kind of log on. Okay, great. So let's start this first session of the Miami Global Brain Tumor Symposium for 2023. Very excited about starting the new year fresh, and of course, I have to thank all of my collaborators and co-directors here at the University of Miami, and all of our administrative support that makes these possible. Going on our 53rd webinar this time with tens of thousands of views, and I just want to thank everybody who continues to tune in and learn from these seminars. For any more questions or information about the University of Miami or our symposiums, you could always follow us on social media, on the web, and especially on YouTube, where we have all of these videos stored. So let's just get to this week. We have our panelists joining us. Actually, Dr. Dagabadi and Dr. Barry were pulled to emergencies, but we have Dr. Morel and Martin coming for us from our fellows, or both our research fellow and one of our surgical oncology fellows. So we thank them for joining us tonight. Today, I have the honor of introducing one of our past brain tumor fellows, Roberto Diaz, who's now a attending and assistant professor of neurosurgery at McGill University in collaboration with the Montreal Neurological Institute and Hospital in Canada. And he's been an active brain tumor researcher and surgeon now for the last 6 or 7 years, and has just done phenomenal work. He does research both in clinical as well in benchtop, focusing on both molecular treatments, both medulloblastoma and glioblastoma, as well as leading their clinical trials at McGill for brain tumors, and their leading brain tumor surgeon. So Roberto, it's so good to see you again, and thanks so much for coming on to give us your insight on this really kind of up-to-date topic, treating metastasis. Just unmute yourself there and share your screen.
Thank you, Dr. Michael Ivan. Always a pleasure to present for the University of Miami group. And I'll just share my screen here. Let's see. I'm going to.
Perfect. That looks good.
Okay. Great. So the title of today's talk is Surgical Management of Brain Metastases in the Era of Targeted Immunotherapy. And first of all, this is a compilation of cases from the last 5 to 6 years and my experience here at the Montreal Neurological Hospital. So you get to hear a bit about how things are managed up north, as they say, in the Great White North of Canada. You might find it's a little bit different than how things are managed down in the States. Obviously, we're a little bit more resource limited, and but I think there's a lot of clinical pearls that can be drawn from these cases, and in terms of decision making, when to operate on brain metastasis, when to refer for radiosurgery, and then how to follow up these patients and manage some interesting phenomenon that happen after use of targeted immunotherapy. All right, so to begin with, we'll start off with this melanoma case. So this is a 45-year-old man who presented. He's actually works up in the north in the forests as a lumberjack, and was on leave in Montreal area, and was found to be confused by his family, so brought to the emergency department and had multiple spontaneously hemorrhagic metastases, including this large 4.5 centimeter anterior temporal metastasis. The imaging was very consistent with a melanoma, although he did not have any primary site, but we could tell on CT chest abdomen pelvis on skin examination. And he had about 10 metastases that we could count easily on the MRI with contrast. This was in July of 2018. So we, at that time, certainly our biggest concern was this large mass with uncal herniation, causing some confusion as well as somnolence. So he underwent an urgent resection of this large mass for both pathology as well as to relieve the mass effect and allow further therapy. We confirmed that it was a melanoma, and this was interestingly a BRAF negative melanoma, so BRAF wild type melanoma. And he went on to receive ipilimumab and nivolumab for 4 cycles, and then nivolumab for 33 cycles, and is now being off treatment for 2 years. And this is what we would consider a complete response. And in fact, I hope this is going to be a cure, because he's now been off treatment for 2 years with no evidence of recurrent disease in the brain or elsewhere. So this patient was lucky enough to present at a time when this article came out, which is combined nivolumab and ipilimumab for melanoma metastatic to the brain in August of 2018. And this clearly showed that in about a quarter of patients with intracranial metastasis that were treated with ipilimumab and nivolumab, there was a complete response to treatment. So in fact, in this significant proportion of patients, I dare to say the word cure, but at least a complete prolonged response can be achieved with dual immunotherapy treatment up front. And so our practice has been to be fairly aggressive at the management of intracranial metastases from melanoma in patients that are naive to treatment, that haven't been received any treatment up front. And we end up seeing a lot of patients that do present for the first time with brain metastasis and have metastatic melanoma. And our primary goal is to deal surgically with the larger lesions that are causing significant massive factor edema, so that the patient can come off of steroids and be started on immunotherapy, or in the setting of, as we'll talk about later, BRAF mutant melanoma, to be started on targeted therapy. So this is another big case. So this is a lady in her 70s, 74 actually, who presented with some gait imbalance, some apraxia, with this hemorrhagic lesion right parietal lobe, but also multiple other smaller hemorrhagic metastases, including one in the left insula, posterior insula. She underwent surgery of the larger lesion here. We confirmed it was melanoma. It was carried the BRAF V600E mutation. And she ended up having radiosurgery to the lesions, but unfortunately ended up showing progression of disease in multiple sites, but specifically in the insula as well as the left occipital lobe. So despite being started on initial cycle of immunotherapy with ipilimumab and nivolumab and receiving radiosurgery, with this progression, she had to be admitted, restarted on steroids for symptom control. And these lesions progressed to become hemorrhagic. So at this point, we really didn't have many more options. Obviously, she's a frail lady in her 70s with multiple progressive lesions. So she was started on a BRAF and MET inhibitor. And this is, I just want to show you the course. So this is what we started off with here at the completion of the first cycle of ipilimumab, nivolumab. And this is where we ended up in 3 months. You could see the marked response. It's not a complete response, but these lesions, the hemorrhages resolved and they started to involute. And I suspect this patient would have had continued response. Unfortunately, she had quite a tragic event at home. She actually had an unwitnessed fall down the stairs and ended up in a trauma bay with cerebral contusions and a very poor neurological exam. And the family opted for palliative management. And so she succumbed from her traumatic brain injury, her cancer, at around 8 months after diagnosis. So I just wanted to put this case into context because I remember when I started medical school, we would get these patients on the medicine ward because they would come in with multiple brain metastasis and they basically would maybe get whole brain radiation and they wouldn't receive any systemic therapy and then be transferred to the medicine ward for palliation. And so I think the management, at least in the last 10 to 15 years for melanoma patients, has really come a long way, even in patients who are elderly with melanoma. And so this is just a great case example where if you're able to get intracranial control, these patients can do very well. And this was, unfortunate case that this patient had a fall at home, which is a common thing for elderly. But she was, independent at home with some minor family supports. So you can really make a significant impact on these patients using a combination of surgery and then engaging our radiation oncology and medical oncology colleagues in the management of the other lesions. And the second point here as well is when not to operate. So certainly you could think about going after these two other lesions, but they're not necessarily superficial or deep. This is in a dominant insula in a 74-year-old where you can't really do awake surgery, and in a frail patient who's already been through one cycle of immunotherapy. So I think it's important to choose your battles, pick your time to operate, and certainly when patients are in the middle of chemotherapy or faced with significant frailty, consider other options. So unfortunately we don't have access to laser therapy. That may have been something else to consider in this case. I'm sure that for surgeons who use laser a lot, that may have also been an option, and it's always a tool in the armamentarium to deal with these lesions. But certainly when these tumors have markers for response to targeted therapy, they can respond. And we know from the clinical trial, this was the clinical trial of BRAF mutation and BRAF kinase inhibitors in conjunction with stereotactic radiosurgery for melanoma metastasis. Jason Sheehan, you can get their group had a 94% median survival at 6 months, 58% at 1 year in the setting of metastatic disease, which is quite a game changer compared to what we were doing back in the early 2000s. So just moving on. So this is a case of a lung
Can you just talk a little bit, Roberto, about for predictors of are you using anything now for predictors of response, or how are you deciding between starting with BRAF or immunotherapy on those melanoma patients?
So that's a great question, whether to start with a dual immunotherapy versus BRAF. So if they have a BRAF mutation, we have the option of using the BRAF targeted therapy. But our oncologists actually prefer to start with immunotherapy. And the reason is that they feel that, as I demonstrated earlier, that in certain cases, you can actually achieve a cure, or at least a long-term complete response with immunotherapy. Something that you don't really see with the targeted therapies. You do see a response, but the sustained dramatic responses that you saw there with the first case, we achieved with immunotherapy and melanoma. So they keep the BRAF inhibitors, MEK inhibitor, as a backup, if the immunotherapy doesn't fail, doesn't show early response, then we would switch to the BRAF inhibitor. But it's a good question. I'm not sure if that's widespread, that kind of reason.
I think I don't think there's really the right answer just yet, but I think it brings up the point that your levels of PD-1 expression and these tumors don't necessarily always correlate to the response, and so I don't think we're quite ready to know what the right predictor of response is going to be.
Yeah, so for the melanoma, we don't rely on the PD-L1 levels of the expression. That's different for the lung cancer population. Right. But I think we kind of just rely on that they're quite immunoresponsive tumors. So, if we can move on, that's a very good point in terms of the immunotherapy, because so this is a patient who was not a candidate for immunotherapy after resection of his lung cancer metastasis. He was PD-L1 0%, ALK negative, and ROS negative. But he had, we do a standard DNA mutation panel, sequencing panel. And he was found to have an EGFR exon 19 deletion, which makes him a candidate for EGFR targeted therapy. And this patient was a 66-year-old lady who presented with some left-sided weakness, which resolved postoperatively, probably just due to the edema. This was a tumor that was just anterior and superior to the insula at the frontal-insular junction, and she went on osimertinib treatment, and this is now 3 years out on osimertinib treatment, and you can see there's just a bit of enhancement at the resection margin, which has been stable on multiple scans. And we see this often with the EGFR targeted therapy, and in patients that receive radiosurgery after surgical resection, they tend to get a bit of an inflammatory response at the surgical site with treatment necrosis, but it really is not associated with a lot of edema surrounding it. So just scar tissue in that zone. And that doesn't require any steroid treatment. These patients do very well. Osimertinib is very well tolerated overall, and she's independent at home with no recurrent disease 3 years out. There's a question. Do you want to save those to the end? We'll just
we'll get to the questions at the end.
Yes, we'll just wait to the end.
Please ask questions so we could
Yeah.
have that discussion.
Okay. So are you still seeing the screen?
No, it disappeared.
It disappeared.
Here we go. Okay, that's
Okay,
better.
perfect. Okay. So yes, this is the clinical trial that came out in 2018, looking at the CNS response to osimertinib in patients with EGFR mutated non-small cell lung cancer, and you can see the dramatic change in CNS progression. So only 20% CNS progression versus 39% with other EGFR tyrosine kinase inhibitors. And so this is our go-to targeted therapy now as a first line for EGFR mutated non-small cell lung cancer. A slightly different case. So this is a patient who presented with again confusion, a visual field deficit, some somnolence. You can see some early oncoherniation. She had urgent surgery to remove this lesion, relieve the mass effect. The pathology showed along adenocarcinoma. There's PDL 20%. That was ALK negative, ROS negative, and had a KRAS mutation. And so he was started on immunotherapy, and this is now 3 years out. And in the interval of time, there were you can't quite see it, but you might see it a little bit here. You see, there's these small. There's one there. There's another one more posterior. These little small metastasis, kind of subcentimetric metastasis along the hippocampus and parahippocampal gyrus, and these were treated with radiosurgery. And he also had radiosurgery to the resection margin. It was 18 grade to each of the smaller lesions, and then 14 grade to the resection margin. And then went on to have immunotherapy. And he developed this inflammatory response. It continues on immunotherapy. We ended up not starting any steroids in this patient. And in fact, he didn't need it. He was KPS of 90 at home, independent. He had a bit of short-term memory changes, but was very, very well at home, golfing, and didn't have any obvious mass effect from this lesion. So we actually cover a very large area, geographic area for our province, and this patient lives about 12-hour drive from from Montreal, and so he ends up getting his MRI there. They ship it down to us, and we review it every so often. And we kept on telling them, listen, this is not recurrent tumor. This is a radiation necrosis or inflammatory response related to his radiosurgery and his immunotherapy treatments, and so educating your colleagues in the community as you see more of these cases is really important. And obviously we do close follow-up with the MRIs initially every month, and then every 2 months to ensure that this is not an evolving process. It's not leptomeningeal carcinomatosis. But two of the key markers here were that there wasn't really this edema related to this, which you normally see with leptomeningeal carcinomatosis, and there was no mass effect, and it wasn't progressive. Right? It was relatively stable. It would change. Sometimes you see a new spot here or there, but it wouldn't be an evolving process. And so he's 3 years out now with this MRI, which we're totally happy with. He completed his immunotherapy actually, because we only keep it on for 2 years if there's complete response, and is now on active surveillance. So we hope that he continues to have a complete response. And here you were mentioning, Dr. Ivan, about whether the PD-L1 levels have any correlation with the response, the ultimate response. We had relatively low levels, right? 20%. It was relatively low, but we still had quite a good response to therapy. So I don't think we still don't have a definitive biomarker to really gauge how well it's going to respond to immunotherapy, but certainly we tend not to give it for PDL0 metastatic lung, but we will give it for anything above 0. We'll tend to get it with immunotherapy. So, the other point here, as surgeons, we would be tempted to go back in here and do a biopsy. And so when therapy, it's really important to gauge the risk benefits. But certainly they're at a higher risk of developing perioperative infections, given the stimulated response. They may have other inflammatory responses like in the lung or skin related issues that could result in breakdown at the surgical site, and they have to be careful about operating in those settings. That being said, we have operated on patients that have received recent immunotherapy. It's usually not a major problem as long as there's no skin inflammatory skin reaction type situations. But it's okay to follow them by imaging and do serial imaging, and we're almost forced to do that in our situation because these patients live so far away and they're quite remote areas. So we've become more comfortable with sitting on these and watching them when we see that typical pattern for treatment necrosis. But certainly you would, one of the options is to do a biopsy and to confirm the diagnosis here. So yeah, so this was just the report on series, a compilation of brain metastases treated with SRS and immunotherapy, where they looked at the freedom from symptomatic necrosis in patients that had SRS alone versus SRS with immunotherapy, and you can see that there's a higher proportion of symptomatic necrosis or radiation necrosis in patients receiving combined immunotherapy and SRS. And it's about like 20% difference in the symptomatic necrosis overall. Okay. So just something to keep in mind. It's definitely, we see it more often in the patients that are on immunotherapy if they've received radiosurgery. So this is switching to a patient with breast cancer. So obviously, I'm not going to go through all the different subtypes of breast cancer. There's a myriad of very good subgroup specific treatment options for these patients after surgery, which can include radiation and chemotherapy, but as well other specific hormonal therapies. So I'm not going to go through the whole gamut of it, but we do see often patients with HER2 positive breast cancer present with brain metastases, and in these patients we tend to be a bit more aggressive surgically, and the reason is that they have quite significant multiple treatment options on the medical oncology side. This is a patient that presented with gait instability, with this progressive lesion that and had quite widespread metastatic disease. So she had brain, lung, liver, and bone involvement. But we knew that this was a ER positive, HER2 positive cancer. We went in, did a gross total resection of this lesion, and the patient went on TDM1 postoperatively and had a survival of 16 months. I'm sorry, I think this is the wrong slide. There's a slide that snuck in here. I just skipped this one. So rituximab TDM1 in patients with HER2 positive breast cancer has been shown to be quite effective. So this is a therapy that combines an antibody that binds to the HER2 receptor. So rituximab, which is the commercial name is Herceptin. But it's not just Herceptin, it's Herceptin that's linked to a molecule that actually results in depolymerization of microtubules. So this essentially, we have Herceptin binds to the HER2 receptor, is internalized, and then the Herceptin molecule is cleaved away from M-tensine, which is the DM1 part. And the DM1 actually has direct effects by binding to microtubules, and this impairs cellular proliferation. So it's really quite a neat therapy, which does result in quite important either partial or complete response in patients. So this is about 25 out of 126 patients had either partial or complete response in their brain lesions. So this is when we're talking about actual therapeutic effect on cerebral metastases, not just extracranial disease. So we combine this, knowing this, in fact, we combine the strategies of surgery with the fact that we can really treat the microscopic disease and maybe other smaller metastases with this type of therapy. And the downside of this is that it is associated with increased risk of radiation necrosis when combined with radiosurgery. So we tend to strategize and treat with SRS, and then if there's systemic disease that needs to be treated, then they would start the TBM1. Or if we want, if they haven't had radiosurgery yet, we tend to prioritize doing the radiosurgery and then not immediately starting TBM1 in combination, but after the radiosurgery is completed. The issue in terms of the timing and what the pathological mechanism of this is slowly starting to be known. This is a great paper where they actually looked at what could be happening in the astrocytes in these patients that receive TDM1 and radiation. And in fact, we were able to show that there's swelling of the astrocytes when given TDM1 and radiation dose of A-Prey. And this was associated with an increase in the water transporter or water channel, the alpha-chlorine 4 transporter. So it appears to trigger some type of signaling cascade that results in astrocytic swelling, and we know that the astrocytes are very important for maintenance of the blood-brain barrier and preventing inflammation that way. So just something to keep in mind. Keep an eye out for radiation necrosis in these patients after they get their radiosurgery. So, I just wanted to summarize sort of my goals of surgery in metastatic disease. I think a lot of it's come through the cases, but just to kind of summarize here again. So we want to achieve tissue diagnosis that's suitable for molecular and genomic testing. And this is key, right? Because it's a lot of our therapies are after surgery are guided by the pathological and molecular diagnosis in these cases, and it's not always clear that the tumor that's in the brain is what's the primary that we're seeing in the body. And so we've had cases where we've had a prior diagnosis of a particular cancer, either breast or lung, presenting with a brain lesion thought to be related to the prior cancer that was treated, but we go in and remove the metastasis and it's something else, melanoma, colon, we've seen. Or for example, we've seen breast, which then presents with lung cancer and with new lung lesion and metastasis in the brain. There's a great study from Harvard that looked at the comparing primary site genetics to genetics of the metastasis, and found that there was quite a divergence between the primary and the metastatic lesion. And so we always want to confirm the diagnosis and make sure that we're able to target the lesion in the brain. So that's key. It's always at the back of our mind, confirming the diagnosis. Second, as I showed those cases where you have patients who presenting in extremis. Unfortunately, we see that a lot here. Or we'd say a large proportion of our population has poor access to primary care. and we see patients presenting with advanced stage cancer, stage 4 cancer quite often, and with these large metastases in the brain. And so the key there is to not not kind of put these patients in the road towards palliative care immediately. There's certainly some cases where that's quite appropriate, but our role, at least I see my role as a neurosurgeon oncologist, is to really take a quarterback role and manage these patients and lead the team in terms of, okay, so what's the priority here? What's going to kill the patient first? And can we buy this patient some time to figure out what the disease is and if we can treat it aggressively? And so obviously that's not appropriate in some cases, advanced dementia, a disease that's involving some systemic site where patients really not going to respond to therapy, but we try to give the patient the benefit of the doubt in terms of trying to see what this is and giving them time to receive additional therapy. So we really want to relieve mass effect, relieve as much as possible the edema in order to reduce the length of dexamethasone use, and especially in those patients that will go on to receive immunotherapy. And it's, as part of this also, I'll talk a bit more in the next slide, but this concept of KPS. And so it used to be that when patients with metastatic disease presented, we referred to the recursive partitioning analysis, and we looked at age, KPS, and extent of extracranial disease or control of extracranial disease as prognosticating markers, and also to try to stratify patients through different treatment algorithms. And so this thinking is really 1990s thinking. We obviously have evolved to be more cognizant of the role of histology plays in prognosticating, and really looking at the role of neurosurgery in terms of reducing the disability and basically reversing disability or stabilizing disability. So by reversing disability, obviously if we have hemiplegia related to mass effect or edema without invasion of the corticospinal tract, by stabilizing disability, I mean primary motor cortex metastasis that's greater than 2 centimeters that we know will not respond very well to radiosurgery. Do we go after that or not? Well, if it's in the face area, we can certainly go after it and preserve their arm and function, or preserve their gaits if it's going to be extending into the corticospinal tract inferior. So even with eloquent region metastasis, we know that we can offer patients the ability to either preserve their function, regain their function, or stabilize their function. And then ultimately, this is towards getting them to getting appropriate systemic therapy. And then finally, our ethos here is to optimize local control and ultimately achieve brain control so that we avoid neurological death and give the patient the best likelihood of having a response to their systemic therapy in that case. So a lot of things to consider, but this is kind of just how I kind of approach the problem. Certainly some of the things that were no-go zones, no-go areas in the past, we can now get by. So deep metastasis using tubular retractor systems to reach some of these deep periventricular metastases, avoiding white matter tract injury. use of laser therapy for certainly hard to reach metastases, surgery in eloquent regions, and then surgery on multiple metastases. And when there are multiple symptomatic metastases, and there is a clear hope for the patient to receive therapy that will prolong their life from a systemic point of view, we do go after more than one metastasis. And it's quite reasonable to do so. Certainly take into consideration the patient's general medical status and whether they can tolerate that. We know that tumors, now there's tumor-specific adjuvant therapy and prognosis, and so it used to be that I would refer a lot to the RPA for prognostication and the new modified RPA classification with using the different subgroups for metastasis for melanoma, breast, and renal cell carcinoma categories. But more and more now, I'm basically will not give a specific prognosis ahead of time before we have a final pathology for patients, because they can vary quite widely as you saw in those cases we presented. Last was a harp on this. The RPA classification is no longer sufficient prognostication. It's a good start. It's a good way to start thinking about the case, and certainly we always look at these things. But for example, that patient that had the metastatic melanoma with more than with 10 brain metastases, right? He was like came in and was bedbound essentially at the time that we operated from that large temporal metastasis. So, upfront QPS is not necessarily the best predictor, especially in a setting where you can improve neurological status with your surgery. So, a case example. This is a 56-year-old lady who presented with hematuria for 3 months. Was seen in the community by a urologist, referred to the university hospital, was found to have muscle invasive bladder cancer, urothelial carcinoma, and was planned for bladder resection. And while getting all her workup for that, she started in the clinic. She started to be confused and having some word finding difficulties and some balance issues and weakness on her right side. So she had a CT scan, and then the MRI showed this large parietal mass. So untreated bladder cancer now with a large parietal mass, which is some atypical features of a metastasis, if you think it's a metastasis, right? So our working diagnosis was a large metastasis, and she hadn't had therapy yet. We know that urothelial carcinoma is actually quite responsive to chemotherapy and radiation, and so in conversation with her, we decided to go after this lesion. Would you guys do anything different in Miami?
Yeah, I mean, obviously, it's a concerning scan, right? I mean, you have significant flare signal, significant mass effect, neurological symptoms, and so the question is always, if it does respond to chemo, is it going to respond fast enough? So, what'd you guys do?
Right. And she's doing great. She's ambulating with a walker. Her speech is normal. This was a big mass, but it's a metastasis, right? A lot of
Yeah.
it is just pushing the adjacent brain. So we just did a en-bloc resection, and she was accepted to rehabilitation, and she's going to start radiation and chemotherapy. And she's off of Decadron, which is a key thing here. And you know, we have a pathology. We confirm that it's not something else, because you know, the other thing is it's kind of an odd-looking metastasis. You don't see metastasis that huge, and it had an invasive pattern. And in fact, our pathologist commented on how there's islands of cells within the white matter that we gave her that are distant from the tumor margin. And so this is an invasive pattern of this metastasis that almost looked like a glioblastoma in terms of its invasion into the white matter. But she's doing well, and you know, hopefully she'll get the chemotherapy and some response. And these patients actually, that they can have up to a 40% response rate with stable disease at 1 year. So you know, we've given her more time to receive her adequate treatment for her bladder cancer. So just kind of to summarize that in terms of our paradigm for new diagnosis of metastatic disease. So we really want to focus on the extent of disease. We do CT chest, abdomen, pelvis, PET scan. We look at the comorbidities. We work with our medical colleagues to really get a good general medical assessment of their preoperative comorbididities. Importantly, their diabetes, their lung function, if they're smokers, long-time smokers, COPD, management, atherosclerotic disease, and then in most cases, when the tumor is greater than 2 centimeters, our preference is to operate. And as I mentioned, we don't have access to laser here, but we will use our micro surgery techniques to access the deep lesions and their superficial lesions, and then plan for radiosurgery postoperatively. We have been starting to look at preoperative radiosurgery or fractionated radiosurgery in patients with greater than 2 centimeter metastases that are still less than, kind of in the range of 2 to 3 centimeters. There's been some reports that actually can reduce the risk of rectomeningeal carcinomatosis in the future. And so we've been experimenting with that as well, and hoping to open a clinical trial soon here, looking at that aspect of the disease. But in most of our settings, we do postoperative radiosurgery to the tumor bed, and then patients will go on to receive the targeted therapy, immunotherapy, or chemotherapy, depending on their pathology. For lesions under 2 centimeters, we prefer to give upfront radiosurgery, and then treat with the primary site with radiation targeted therapy or immunotherapy. And these patients are followed closely, even if they're not operated. We do continue to follow them, and the way we work here, actually, the radiosurgery is done at a separate site, so it's actually done by radiation oncology colleagues and planned and executed. It's not we have a cybernetic system, but we end up following these patients even with the smaller metastasis, because eventually they will develop other metastasis, and occasionally they will progress to either radiation necrosis or fail radiosurgery and require surgical intervention. So it's important to keep a close follow-up, either in combination with your radiation oncology colleague or in the clinic. I tend to see my patients early on postoperatively, and then 1 month after the radiosurgery is completed, and then follow up every 2 to 3 months thereafter, depending on their burden of disease. Sorry. Trying to go back. Okay, let's see. Okay,
Great.
so that's great. Yeah. So that's the end of it there. I'm going to open it up to questions, and I think it's let's really go back to the cases or show some other cases as well. We have access to our PAT system.
Great discussion, Roberto. It's an evolving and complicated area of neurosurgery that yet is a very large part of our brain tumor practice. And so staying up to date on the chemotherapy and not just the surgical techniques is becoming even more important for these for the treatment of these diseases, especially. And that's that's
yeah, I mean, it's true. It's difficult for the practicing neurosurgeon, especially out in the community, to keep abreast of all these advancements. And even for us in the university center, I'm always on the phone with my medical oncology colleague because there's always something new, secondary treatment options. It gets even more complicated at recurrence. So it's a good dialogue with your radiation oncology and medical oncology colleagues is really important. I think that's one of the pearls from this discussion for sure.
Alexis, do you have any questions?
I do. Nice to meet you, Roberto. It was a great talk and very, very, very exciting field. I have a short question. Have you seen any cases of hypophysitis in these patients?
Yes. So we've seen one case of hypophysitis. They tend to get better with switching to a low dose steroid, like dexamethasone, usually, or prednisone. The thing that we see more often actually is adrenal insufficiency with long-term immunotherapy, and so there's a good portion of these patients that do end up on hydrocortisone for adrenal replacement therapy. Yeah.
Great. And any other potential complications that you have seen?
So interstitial pneumonitis. I was mentioning, make sure if you are going to operate on someone on immunotherapy that their lung status is stable. There have been some reactions, rashes, and then as you mentioned, the hypophysitis, but the adrenal insufficiency is the one that, from a surgical point of view, that's the one we worry about most, right, for adrenal crisis, so that they have appropriate stress dosing if they develop an infection or if they if they go to surgery.
Perfect. Thank you.
Martin, any questions?
Yes. So thank you for your talk. They were great cases to learn from. I have a question regarding how, in the context of immunotherapy, what's your opinion regarding when to consider progression of disease in these brain metastases that are being treated with immunotherapy, taking into consideration that a few years ago the Reino group published this paper, kind of modifying a little bit their criteria to define progression disease in clinically stable patients, even when a new lesion arises, like in the first 6 months of the treatment. So what's your opinion that when it's a good moment to stop the treatment and consider it a progression of disease, when to continue and wait a little bit to see how the patients evolve?
Yeah, so that's a good question. So first of all, it's dependent on the histology. So if we're talking about melanoma versus lung cancer, in patients that have systemic control of the lung cancer, but develop new brain metastasis on immunotherapy, we tend to treat the new brain metastasis and continue the immunotherapy. Especially if they've had, PDL positive lung adenocarcinoma with a good systemic response. So our oncologists tend not to stop it for the brain progression, but if they progress systemically within the lung or liver. For the melanoma, it gets a little bit more complicated because it depends on whether you have other options to consider. If it's progressing for melanoma, they tend to look at other treatment options. In those cases, whether it's switching, I guess it also depends on whether they've been previously treated on immunotherapy and now on kind of a holiday period, or they switched over to nivolumab alone from the Nivo to nivolumab alone. But certainly, if there's a BRAF mutation, they'll tend to look at the targeted therapy options.
Thank you.
There was one more question from the crowd. I think Alexis kind of already alluded to it, but do you see any hypopan-pituitarism, and does this kind of go along with some patients doing better than others?
Yes, we do see the hypophysitis.
Right.
And
Sorry, does that
I
affect?
haven't had a relationship. So it's not a common complication. It does happen, but it's not that common.
Pretty rare, right?
Yeah, so it's hard to make a correlation between that response and the clinical response to the cancer.
What have you been doing with the monitoring response rates? Do you use any kind of different modalities in your MRIs, such as metabolic profiling or perfusion or anything like that, to kind of see early response versus inflammation? What's the protocol up there?
Yeah, so this is the bane of our existence, right? Trying to figure out if it's recurrence, progression, or radiation necrosis, right? So we typically use the cerebral perfusion imaging on the MRI and got cerebral blood volume. It's not 100%. No study has shown that there's a gold standard for radiation necrosis. We tend to see more often low CBV with the radiation necrosis lesions compared to those that show progression. One of the studies I really liked, Dr. Hinojosa's study, Camilo Hinojosa's study from a few years ago, where he looked at he looked at all the cases where they biopsied for radiation necrosis versus recurrent metastasis, and they put that on a timeline of like less than 6 months, greater than 6 months, and typically the lesions that tended to be radiation necrosis tended to recur after the 6 month period. The ones that were progressive disease tended to be recur early, and evolve with progressive enhancement before 6 months with a lot of edema. So I like to refer to that study, and they give good proportions in terms of, so if it was almost 50-50 for those that show enhancing progression after 6 months. It was almost 50-50 whether it was recurrent disease versus radiation necrosis. And so I like that study. I've thought that a lot. Sometimes you can just look at it from the morphology and how the patient's doing, whether they're still active, not having any neurological deficit from the lesion, and it's not progressing, not evolving. But we tend to just look at serial MRIs, like the Rainer criteria, look at serial MRIs. If there's a massive cut that's progressive with lots of edema, our preference is to go in and remove it and get a good sampling of this lesion. Actually, interestingly, I was gonna show one, but it wasn't. It was a squamous cell carcinoma in a gentleman I treated in 2017. Right frontal squamous cell carcinoma. He had a lobectomy and was disease-free in the body, and then presented with this right frontal, quite a large right frontal cystic metastasis. We removed it completely. He had radiosurgery to the margin, and then presented with just a rapidly evolving, enhancing margin with significant edema, hemiparesis. And so we went in and did an en bloc resection of that, and it was all radiation necrosis. And we didn't have to treat him with Decadron for a long period. He's gardens, he brings me tomatoes every summer.
Yeah.
He's disease-free on no systemic therapy. So it's incredible when we do get this response. It can look very much like recurrent disease.
Yeah, it's great to show the 3-year scans where you have the remission, but we all know that sometimes it's a roller coaster ride of MRIs.
Yeah, no, for sure. That's I still follow him every 3 to 4 months, and
Sure.
It's great, but it's he's now 5 years out in 2017. So some of these squamous cell lung cancers, when they have had primary surgery with no disease systemically, can have quite long survivals. So we tend to be the best kind of those as well.
Yeah. Great. Well, thanks again for a great talk, and also congrats on the great outcomes on those patients that you showed. It really does show promise, and it's an exciting time to be involved in this area. So anyway, thank you so much again. Stay safe, and hopefully we'll see you soon. Okay.
Thanks, everyone. Have a good evening.
Bye.